Hi everyone, and welcome back to 5-Minute Medicine. In today's video, I'll be giving you a brief overview of urinary incontinence. So the main types of urinary incontinence are urge, stress, overflow, and functional incontinence. Now I would like to spend some time on each one of those types. So the first one is the urge incontinence, and it is essentially the urge to pee which leads to uncontrolled leakage, and this can be just a couple drops or a complete bladder emptying, and that is caused by detrusor overactivity, and that can be caused by things like such as stroke, but in some cases it is also idiopathic, meaning a specific underlying cause cannot be found. Some of the important risk factors to remember for urge incontinence are diabetes and neurological disorders, so stroke or Parkinson's disease, as well as obesity and pelvic surgery. The next type of incontinence is stress incontinence. In stress incontinence, you have pressure on the bladder, which leads to leakage. So people will come complaining of peeing after they've laughed or after coughing, and it can be quite embarrassing to them. So it's important that you listen to the history and pick up the clues, which can help you determine which incontinence type it is. It is caused by an incompetent sphincter, and some of the risk factors for stress incontinence are pregnancy and childbirth, especially vaginal deliveries, obesity and pelvic surgery. But pregnancy and childbirth would be one of the main clues to look out for in history. Overflow incontinence is caused due to a problem with emptying a bladder, and specifically there is an obstruction in the bladder outlet, and it can be something like pelvic tumors in women, or in men it could be prostate hypertrophy. Functional incontinence is caused by physical comorbidities which make it impossible for the patient to get in bathroom on time. However, quite crucially, the bladder itself functions normally. The causes for functional incontinence are things such as dementia, decreased ambulation. So, for example, patients who may have had a hip replacement, they struggle to get to the bathroom on time. They might be worried there's something wrong with the bladder, but actually it's more so the fact that they're unable to get to the bathroom on time, unlike someone else who is completely healthy. Now that I've given you this brief overview of each one of those types, I would like to talk about the different investigations that can be done. So most important is the history. It will give you all the clues. If someone's coughing and peeing themselves doing so, it is leading you towards stress incontinence. If someone gets sudden urges to pee and cannot control them, that can point you more towards urge incontinence. But other investigations include a bladder diary, especially for at least a period of 3 days, a urinary dipstick. It's important in all patients who present with urinary incontinence to exclude things such as a UTI. And then some of the simpler tests is something called a cough stress test, in which case a patient is asked to cough, and it is determined whether there was some urine leakage coming out of it. And if it's positive, it is diagnostic of stress incontinence. Lastly, you can also do something called a post-void residual measurement, where you can use an ultrasound or a catheter after someone's been to the bathroom in order to compare how much urine has been left in the bladder. And if it's over 100 milliliters that's still in the bladder, or over 50% of what has been released during micturition, it can confirm overflow incontinence. Now just a quick overview of the management of the main types. So the first line management for urge incontinence is bladder retraining for at least 6 weeks. However, if that doesn't work, you can go for something like oxybutynin, or if that doesn't work, you can go for mirabegron, but it should be avoided in frail elderly people as it can have anticholinergic effects. Stress incontinence is firstly managed with pelvic floor exercises or with surgery if those don't work. This is a retropubic mid-urethral tape procedure, that helps treat it. Or if people do not want to undergo surgery, you can go for duloxetine. Overflow incontinence has to be treated by treating the underlying cause, or patients can be catheterized in case it is impossible to treat the underlying cause at the time. Whereas functional incontinence, whilst isn't on this slide, can be treated by supporting the patient in any way that you can so that they can get better and hopefully improve their mobility. That was a very quick overview, and I hope it is useful. If you have any questions, please leave them down in the comments. I'll be more than happy to answer them. All the investigations and management have been based off of the 2022 UK guidelines. So depending on where you live, this might not exactly translate, but I hope it is giving you a good overview of incontinence. Thank you so much for listening.